Hope we are audible to everyone. The voice is clear, and if you have any issues, please raise your queries in the questions tab. We will start with the lecture in a minute. If you are not able to listen to the audio or see the screen, please raise your questions in the questions tab. इसको मिनिमाइज ही कर देता हूँ, मैं स्क्रीन को इंटरफेयर करेगा.
Can somebody unmute and tell you? We are able to see and listen. It is clear, sir. This is Saket. Saket में रह गया.
Okay, so as the feedback has been received from some of you, you can hear it properly and you can see the screen. If you are having any issues, please make sure you check your net connection. And if you don't hear the audio, you can connect to the audio using the calling feature. So we are starting with the lecture now, and I am handing over the screen to Dr. Suneela Garg.
Thank you, Dr. Ruchir. And good morning, students. After a long time, we are starting our classes, and that too through a advanced mode, that is a webinar mode. So the first series, which is a very, very burning topic, which we are going to take up today, is on COVID-19 and epidemiological perspective. Next. So you know that basically the disease started with a cluster of pneumonia cases of unknown origin in December 2019 in China. And you can see in the map of China, it was in the Hubei province of China. And on the left side, you can see the map X-ray of the patient with the pneumonia. Cluster of pneumonia cases of unknown origin was there in December 2019. And as you can make out that from December 1, 2019 to January 2, 2020, when the market was closed, out of 41 patients, 66%, that is 27, had exposure to seafood market. And this has been published in Lancet as well. Now, if we look at some of the very important timelines, on 12th December 2019, Wuhan reported the first case. 31st December, Chinese authorities, they alerted WHO about cases of pneumonia of unknown etiology. On 1st January 2020, Wuhan seafood market was closed because of regulation and disinfection query. And then on 3rd January, gene sequencing was done and India was notified by WHO. On 8th January 2019, novel coronavirus was identified and South Korea was the first possible case, and WHO confirmed novel coronavirus, and which was isolated. And then subsequently between 12th to 14th January, we also had Wuhan's first death of 61-year-old male with possible human-to-human transmission, and confirmed cases were outside Wuhan, which was there in Guangdong, Beijing. And on 13th January, Thailand also confirms first case outside China. Between 17th to 20th January, Hong Kong, Singapore, Japan, Korea, USA, they all confirmed cases. And on 25th January, WHO confirms first human-to-human transmission outside China in Vietnam. And on 30th January, WHO declared it as public health emergency of international concern. On 11th February, virus was renamed as SARS-CoV-2, and the disease is commonly known as and popularly called as COVID-19. It was named on 11th of February. On 11th March, WHO declares it as a pandemic, and on 19th March, number of cases confirmed have exceeded 2 lakhs, and today we are approximately more than 8 lakhs. Now, if we look at timelines in India, on 30th January, we had first confirmed case in Kerala, and in February, the 3 confirmed cases in Kerala recovered. On 2nd March, we had confirmed cases in Delhi, Jaipur, and Hyderabad. And on 3rd March, government suspends visa to Italy, Iran, South Korea, and Japan. On 4th March, confirmed cases in NCR and Jammu were there, and Ministry of Health and Family Welfare announced compulsory screening of all international passengers. And on 11th March, we had 60 confirmed cases, and on 21st March, total number of cases were 231, including foreign nationals. Now here you can see a snapshot of WHO map, and this is a map which is updated on 31st March 2020, which is actually a data of 30th March, which is showing 7,19,758 cases and 33,673 confirmed deaths, and which have been reported from 203 countries. Now, current scenario in India is quite grim. We do have, not as bad as other countries, because we still deny our community transmission, because number of confirmed cases are 1397, and first case, as I told you, was shown on 30th January 2020. Now, this is how we calculate the data in the world, as I told you, approximately, and this is the data of 30th March, where we had 7,23,390 cases. And how we express the cases is total number of cases per million population in the world have been 98.2. Number of deaths per million population have been 4.4. And the first reported case was on January 10. Now, if we look at the etiology now, if we look at the core cause, this is an enveloped positive single-stranded RNA virus. It has a crown-like appearance on electron microscopy. It is divided into 4 genera: alpha, beta, delta, and gamma. And alpha and beta coronaviruses are the ones which are infecting human beings and infects mostly bats, pigs, and small mammals. And it mutates very easily, so it is challenging from the vaccine perspective as well. So you can see the coronavirus with all the proteins on the right side, that is S protein, M protein, E protein, which are there in the viral envelope, and also in the core you can see RNA, nuclear protein, and HE protein as well. Now, as far as continuing with the etiology, out of 7 known species of coronavirus, only 3 are known to cause severe infections in humans. That is SARS-CoV coronavirus, which emerged in 2003 in southern China from the civet cats, and MERS-CoV-2, which emerged in 2012 in Saudi Arabia from dromedary camels. These are Arabic camels. And SARS coronavirus 2, which emerged in December 2019 in China. Then also we have 4 human coronavirus, that is HCOV229E, NL63, OC43, and HKU1. They are endemic globally, and their importance is that they are responsible for 10 to 30% of upper respiratory tract infections in adults. Rarely animal coronavirus infect people and then spread between people, such as SARS, which happened in 2002, and MERS in 2012. Now, how contagious is the disease? This is how we determine the contagiousness of the infection. Now, how we signify it is approximate reproductive number, that is R naught. R naught is average people who will catch infection from the contagion, and in cases of COVID-19 it is 2.8, and in comparison to this, measles has got R naught of 15. So this is where you see that it is in between above Ebola and less than SARS and less than smallpox and measles. So survival of COVID, if we see why we keep emphasizing that clean your knobs, clean your surfaces and all that, the virus stays in metal on doorknobs, jewelry, silverware for 5 days, on wood such as furniture and decking for 4 days, on plastics, packaging like milk containers, detergent bottles, subway and bus seats, the backpacks and elevator buttons for 2 to 3 days, on stainless steel like refrigerator, pots, pans, sinks, some water bottle for 2 to 3 days, on cardboard shipping boxes 24 hours, on copper, pennies, tea kettles and cookware for about 4 hours, aluminium, soda cans, tin foil, water bottles for 2 to 8 hours, glasses, drinking glasses, measuring cups, mirrors, windows for up to 5 days, ceramics like dishes, pottery, mug for about 5 days, paper, it may survive for a few minutes to 5 days, and food, it doesn't spread. So these are the things which you have to keep in mind. So overall, Swachh Bharat Abhiyan becomes very, very important, taking care of all our surroundings. Now, if we look at some of the important risk factors, people who are aged 65 years and older, people who live in nursing home or long-term care facility. Other high-risk conditions could include people with chronic lung diseases like COPD or moderate or severe asthma, people who have heart disease with complications, people who are immunocompromised, including cancer treatment, bone marrow or organ transplant, immunodeficiency, poorly controlled HIV/AIDS or prolonged use of corticosteroids, people of any age with severe obesity, that is one of the important concerns, or certain underlying medical conditions, particularly if not well controlled, such as those with diabetes, renal failure, or liver disease might also be at risk. People who are pregnant should be monitored. Now, if we look at the case definitions of a suspect case, a patient with acute respiratory illness, that is fever and at least one sign or symptom of respiratory disease, for example, cough or shortness of breath, and a history of travel to a residence in a country, area, or territory which is reporting local transmission of COVID-19 disease during the 14 days prior to symptom onset, or it may be a patient or a healthcare worker with acute respiratory illness and having been in contact with confirmed COVID-19 case in last 14 days prior to onset of symptoms, or a patient with severe acute respiratory infection, commonly known as SARI, that is fever and at least one sign and symptom of respiratory disease, for example, cough, shortness of breath, and requiring hospitalization and with or no etiology that fully explains the clinical presentation, or a case for whom testing for COVID-19 is inconclusive. Now, if we look at who is a laboratory confirmed case, a person in laboratory case confirmation of COVID-19 infection is irrespective of clinical signs and symptoms. Now, what is the definition of a contact? A contact is a person that is involved in any of the following. He may be providing direct care without proper personal protective equipment, that is PPE, for COVID-19 patients. It can be she as well. Now, staying in the same close environment of a COVID-19 patients, that is including workplace, classroom, household gatherings. Traveling together in the close proximity, that is within a meter, with a symptomatic person who later tested positive for COVID-19. Now, if we look at the clinical disease spectrum in mild cases, where we say that there is no or mild pneumonia is reported in 81%, severe disease, that is dyspnea, hypoxia, or more than 50% lung involvement on imaging within 24 to 48 hours was reported in 14%. So critical patients are very important. That means with respiratory failure, shock, or multi-organ dysfunction, this is reported in 5% of the cases. So overall, also in the epidemiology of the disease, our approximately 80 to 85% of the cases they present with mild infection. Now, if we look at, how are we going to differentiate between the common presenting conditions, because we are now having monitoring of influenza-like illnesses also. Now, if we look at the symptoms, on top are symptoms COVID-19, common cold, flu, and allergies. Fever is very common in COVID-19. It is rare in common cold. It is common in flu, but in allergies, sometimes it can happen. Dry cough is common in COVID-19. It is mild in common cold. It is common in flu, and then sometimes it is present in allergies. Shortness of breath is very common in COVID-19. It is not there in common cold. It is not there in flu. It is common in allergies. Headaches are there sometimes, but they are rare in common cold. They are common in flu, and in allergies, sometimes they may be there. Aches and pains are sometimes there in COVID-19. They're common in common cold. Flu has aches and pains, and then allergies, it has got no aches and pains. Sore throat is sometimes present. It is common in common cold. It is common in flu, and it is not there in allergies. Now, if we look at the diagnosis, now diagnosis of COVID-19 cannot be definitely made without microbiological testing. Now, SARS-2 coronavirus 2 RNA is detected by reverse transcriptase polymerase chain reaction, that is commonly known as RT-PCR. Now, limited capacity of the countries may preclude testing of all patients with suspected COVID-19, where now India is accelerating at a faster pace because of the faster availability of the kits. Now, local health department may have specific criteria for testing, and which is true for our country as well, but priority should be given for hospitalized patients to inform infection control decisions, symptomatic individuals who have high risk of poor outcomes, for example, old age, chronic medical conditions, and immunocompromising conditions, and individuals with higher exposure risk. Transmission. looking at the transmission of COVID-19, it is zoonotic, that is, transmission is there from animal to humans and vice versa. Natural reservoir is considered to be horseshoe bat or Malayan pangolins, which is a reptile. It is highly contagious. As I told you, the R0 point also, which was over 2, and it is transmitted via hand, direct hand to face contact, inhalation of aerosol, that is suspension of solid particles or liquid droplets in the air, that is basically the droplets, fecal-oral transmission through fomites such as towels, tabletops, doors, knobs, handles, etc. Now, also, if you see how it attacks the human beings, we also showed you coronavirus has got, different proteins which are there in the outer this thing. And so SARS coronavirus 2, it's binding via its S protein to the host cell through angiotensin converting enzyme 2, which is known as ACE2, and basicin, that is BSG. So ACE2 is expressed by epithelial cells of intestine, kidney, blood vessels, and most abundantly in type 2 alveolar cells of lungs. The viral spike protein induces a drop in the level of ACE2 in the human cells, possibly inducing the lung damage. So this is one of the important mechanisms how the virus is binding with the host cells. Now, if we look at the clinical presentation, incubation period of COVID-19 is ranging from 2 to 14 days. For COVID-19, the data suggests, which I already told you, that approximately 80% asymptomatic, 15% are severe infections, that means they require oxygen therapy, and 5% are critical infections, they require ventilation. Now, the most common complications could be interstitial pneumonia, acute respiratory distress syndrome, which is the most important cause of fatality. And here, through the diagram, you can make out that there are common symptoms in terms of fever, dry cough, flu-like symptoms. Then severe cases, they present with dyspnea, chest pain, hemoptysis, crackles, or respiratory insufficiency. Then also the complications are manifested in form of pneumonia, acute respiratory distress syndrome, cardiac injuries, arrhythmias, septic shock, liver dysfunction, acute kidney injury, and multi-organ failure. Now, risk factors for the severe form of illnesses are normally immunosuppression from long-term steroid use, cancers, AIDS and HIV infections, congenital immunodeficiencies, and use of immunosuppressants. And age, I already mentioned that individuals over 65 years of age are at risk. Then chronic diseases and pregnancy. On right side, you can see a diagram where you see the onset and you can see the 4 parts of it: critical, severe, common, and mild. Now, basically, you see all forms, mild, common, severe, also can lead to a path of recovery as well. But when we look at the isolation, hospitalization, and all that, particularly when we see critical cases, severe cases, and little bit of the common cases, they are much more likely to succumb to infections as compared to our mild cases. So this is the report of WHO China Joint Commission, which was released in February 2020. Now, for diagnosis, as I already told you, we are using PCR test. The specimens which we are using are nasopharyngeal swabs, which are recommended for mild or asymptomatic suspected cases. Second is sputum for patients with productive cough, but inducing sputum is not recommended. Bronchial and tracheal secretions or bronchoalveolar lavage for patients receiving invasive mechanical ventilation. Now, if we look at management, you will see all throughout that infection prevention control measures, that is IPC, is playing a critical role. So there has to be immediate implementation of IPC measures, early supportive therapy and monitoring, collection of specimens for laboratory diagnosis, which we have to do. Simultaneously, we have to manage respiratory failure along with acute respiratory distress syndrome. Management of septic shock and prevention of complications should be our area of attention immediately. Early supportive therapy and monitoring, we have to understand also the patient in totality in terms of if there are any comorbid conditions to tailor the management of critical illnesses and appreciate the prognosis. During the intensive care management of severe acute respiratory infection, determine which chronic therapies should be continued and which therapies should be stopped temporarily. Another very important thing is that communicate early with the patient and family. Tell the patient about the prognosis, and this should be communicated to the family as well. And we have to communicate proactively with the patients and families and provide support and prognostic information on a day-to-day basis and understand patients' values and preferences regarding life-sustaining interventions. Now, regarding the collection of specimens for laboratory diagnosis, as I've already told you also, that collect blood cultures for bacteria that cause pneumonia and sepsis, ideally before antimicrobial therapy. Do not delay antimicrobial therapy to collect blood cultures. Now collect specimens from both upper respiratory tract, that is nasopharyngeal, oropharyngeal, and lower respiratory tract, that is expectorated sputum, endotracheal aspirate, or bronchoalveolar lavage for novel coronavirus testing by RT-PCR. Clinicians may elect to collect only lower respiratory tract samples when these are readily available, for example, if the patient is mechanically ventilated. Now, what is infection prevention and control? Now, infection prevention and control is basically a very scientific approach with practical solutions which are designed to prevent harm caused by infections to the patients and healthcare workers. Grounded in principles of infectious disease, epidemiology, social distance, and health system strengthening. And also it is rooted in patient safety and health service quality. So this is in totality, basically, it encompasses everything, right from the systems to the patient to the infection of the healthcare workers, and it has to be of quality. Now, who is at risk? If you see that there is one individual who is infecting now 5 individuals, and they may be of different categories, and then ultimately this is how there is a chain of reaction, and this is everybody is at risk of infection. So benefits of basically infection prevention control are: you have to protect yourself, you have to protect your patients, you have to protect your family, community, and environment. Now, our goals in infection prevention control in outbreak preparedness are: number 1, we have to reduce the transmission of healthcare associated infections. We have to enhance the safety of staff, patients, and visitors. Another is to enhance the ability of organizations, healthcare facility to respond to the outbreak, to lower or reduce the risk of hospital, that is healthcare facility itself amplifying the outbreak. Role of infection prevention control focal point team or committee basically is that we have to acknowledge about understanding of what are the strategies needed for outbreaks, epidemics, etc. Number 2 is we can assess, we can prepare, and we can have readiness for the committee and for the infection. Then it will also affect our policies and standard operating procedures development. It will facilitate participation in response and recovery, and participate in surveillance and monitoring, patient management, infrastructure for patient management. So overall, you can see that the role of IPC focal point team or committee will provide knowledge, will provide assessment, preparedness, and readiness. It will provide policy and SOPs. It will participate in response and recovery. It will participate in response and monitoring. It will also facilitate patient management, and it will also provide inputs for infrastructure for patient management. And most important is it will play a critical role in education as well. Now, if we look at general advice for COVID-19, on the right side is the poster which you can see, and on the left side I mentioned that avoid close contact with the people who are suffering from acute respiratory infections. Frequent hand hygiene, especially after direct contact with ill people or their environment. People with symptoms of acute respiratory infection should practice respiratory etiquette. Number 1, they should wear a medical mask and they should seek medical care for advice. And always the punch word is stay protected, stay safe from coronavirus. Then again, what are the strategies for preventing or limiting the spread of COVID-19? Apply standard precautions for all patients. Ensuring triage. As early as possible, we remove the patients from the site when they are presenting, early recognition and source control. Implementing empiric additional precautions for suspected cases of COVID-19 infections. Implementing administrative controls and using environmental and engineering control measures. Standard precautions have to be applied to the basic level of infection prevention control precautions to be used for all patients, all times, regardless of suspected or confirmed status of the patient. So fundamental rule is that you will be applying infection control measures or precautions for all patients, all times. Risk assessment is critical for all activities, that is assessing each healthcare activity and determine the personal protective equipment that is required for adequate protection. Now, what are the elements of standard precautions? First is hand hygiene. Second is respiratory hygiene. That is what we call it as the cough etiquettes and all that. If you have to cough, then you have to cough in your elbow. And if you are using a tissue paper, that has to be discarded very, very correctly. Then personal protective equipment according to the risk. Safe injection practices, sharp management and injury prevention. Safe handling, that is cleaning and disinfection of patient care equipment. Environmental cleaning, safe handling and cleaning of soil, linen, and waste management. Now, if we look at the chain of transmission, the core is the chain of infection. There is an infectious agent which is going to come to the reservoir. Then there is going to be port of exit. Then there is mode of transmission. Again, there is an entry and there to the susceptible host. For an infection to spread, all links have got to be connected. But breaking any link will stop the disease transmission. Like if we are blocking the port of exit, we are breaking the chain of transmission. If we are blocking the portal of entry to the susceptible host, we are again, blocking the chain of transmission. Now, best way to take care of the individual and the first and most important focus upon is hand hygiene. So this is the best way to prevent the spread of germs in the healthcare setting and in the community. Our hands are our main tool for work as healthcare workers, and they are the key link in the chain of transmission. And also, you see, we are using our hands for the door handles, for medication, for cell phones and all that. So automatically, we have to make sure that the things which we are handling in our day-to-day life are also kept clean, including our equipments. And we need to look at the medication part and all these things which I mentioned. Now, there are, according to WHO, there are 5 moments of hand hygiene. First is before you touch the patient. Second is before you do a clean or an aseptic procedure. Third is after the body fluid exposure. Fourth is again after touching the patient. And fifth is after touching the patient's surroundings. So these are known as WHO 5 moments. And if you look at the hand hygiene, how are you going to do the hand hygiene so we have shown the hand hygiene techniques also. So first, you see, you are going to apply, the alcohol on and you have seen over here in the diagram, it is very clear that first you're going to take the sanitizer on your palm, then you're going to do it with the right palm on the left dorsum, and then again you're going to do it with the another hand. Then you have to clean your rub your back of the fingers, you see, on the opposite hand, and do it for the other hand as well. Then simultaneously we have to do for the nails as well, and do not forget to clean your wrist. So use appropriate product and technique. An alcohol-based hand rub product is preferable if hands are not visibly soiled. Rub your hands for 20 to 30 seconds. Soap, running water, and single-use towel when visibly dirty or contaminated with proteinaceous material. Wash hands for 40 to 60 seconds. So now here you can see properly also. Duration of the entire procedure is 20 to 30 seconds. Now I'll explain that. Apply a palmful of the product in the cupped hand, covering your surface. Now second is that basically you have to rub the hands from palm to palm. Then you have to, in the third step, you have to bring right palm over the left dorsum with the interlaced fingers and vice versa. Then again in the fourth step, you go palm to palm with the fingers interlaced. Then on the fifth step, you will see back of the fingers to the opposing palms with fingers interlocked. Then sixth is you rotate. The rotational rubbing of the thumb becomes very important, that first you do with the left thumb clasped in the right palm and vice versa. Then rotational rubbing and backwards and forwards with the clasped fingers of the right hand in the left palm and vice versa. Once dried, your hands are safe. So it is very important, in once dried, you need not touch the tap. You have to use your elbow or to close the tap if you are doing the hand washing properly. So this is important to remember, and hand hygiene, remember, is the crux of the thing. And also, when you are looking at how to do the hand wash. First is that was the about hand rub, and second is about the hand wash. Hand rub is with the help of the sanitizer, and hand wash is we are doing it with the help of soap and water. The duration of hand wash is varying from 40 to 60 seconds. You are going to wet your hands with water. You are going to apply enough soap to cover all hand surfaces. Then you have to rub your hand palm to palm, then right palm over the left dorsum with the interlaced fingers and vice versa, then palm to palm with the fingers interlaced, then back of the fingers to opposing palms with the fingers interlocked, then rotational rubbing of the left thumb clasped in the right palm and vice versa, then rotational rubbing backwards and forwards with clasped fingers of the right hand in the left palm and vice versa, and then rinse hands with the water. Dry hands thoroughly with single use towel. Use towel to turn off the faucet, and then your hands are now safe. So remember that hand hygiene is very, very important. I've already told you both the procedures. One is how to hand rub, and then the second is how to hand wash. So hand rub is rub hands for hand hygiene, wash hands when they are visibly soiled. But whenever hand rubs are not available, sanitizers are not available, please focus attention on hand wash, because we will always not have the privilege of having sanitizers. Now coming to respiratory hygiene and etiquettes, it reduces the spread of microorganisms that causes respiratory infections such as cold, flu. Turn the head away from others when coughing or sneezing. Cover your nose and mouth with the tissue. If tissues are used, discard immediately into the trash. Cough, sneeze into your sleeve if no tissue is available. Clean your hands with soap and water or alcohol-based products. Do not spit here and there. And the here down below, the source is also given, that is from the WHO material. So this is where you maintain, how you maintain your respiratory hygiene or etiquettes. Then how do you promote respiratory hygiene? You encourage hand washing for patients with respiratory symptoms, provide masks for patients with respiratory symptoms. Patients with fever plus cough or sneezing should be kept at least 1 meter away from other patients. Post visual aids reminding patients and visitors with respiratory symptoms to cover their cough. So always have this thing in your mind that respiratory etiquettes are very, very important, and accordingly, the masks are equally important when we are promoting respiratory hygiene, and then especially for the patients who are having fever and cough. And always, we must keep reminding that for the individuals who are symptomatic, it is very, very important to wear a mask. Then again, personal protective equipments which are used in the healthcare settings are for COVID-19, which have been recommended, are face masks for nose and mouth. Then we have got N95 mask for nose and mouth. Then we have got face shields which are used for eyes, nose and mouth. Then we have got goggles where we are doing the procedures and all that. Then gown for the body, apron for the body, then gloves, and also head cover for head and hair. Now, patients who are suspected of COVID-19 cases, preferably patients should be in a single room where natural ventilation with airflow of at least 160 liters per second per patient, or in a negative pressure rooms with at least 12 air changes per hour and controlled direction of airflow when using mechanical ventilation. Now, as far as cohort is concerned, or the group of individuals is concerned, all patients with respiratory illnesses should be given a single room and with at least 1 meter away from other patients when they are waiting in a room. There should be dedicated and trained healthcare worker for them. Healthcare workers should be wearing personal protective equipment, a medical mask, goggles, face shield, gown, and gloves. And also hand hygiene should be done anytime as per WHO's 5 moments, which I told you before. Apply before the personal protective equipment and after removing the personal protective equipment. Now, patients who are suspected or confirmed COVID-19, if we go further, equipment should be single use when possible, dedicated to patient and disinfected between uses. Avoid transporting suspecting or confirmed cases. If necessary, have patients wear masks. Healthcare workers should be wearing personal protective equipment. Routine cleaning of environment is very, very crucial. Limit the number of healthcare workers, visitors, and family members who are in contact with the patient. If necessary, everyone must wear a personal protective equipment. Now, all persons who are entering the patient's room, including visitors, should be recorded for contact tracing purposes. Precautions should continue until the patient is asymptomatic. Now, if we are looking at the outpatient care, the basic principles of inpatient care and standard precautions should be applied in all the healthcare facilities, including the outpatient care and primary care. So first is the focus on triage and early recognition. Emphasis should be given on hand hygiene, respiratory hygiene, and medical masks to be used by the patients with respiratory symptoms. And we should consider having a signage where the patient has to go. Now, the next part is that if possible, place the patients in the separate room or away from other patients in the waiting room. When symptomatic patients are required to wait, ensure that they have a separate waiting area with 1 meter separation. Prioritization of care of symptomatic patients is a must. Then educate patients and families about early recognition of symptoms, basic precautions to be used, and which healthcare facility they should refer to. Now, home care for patients with suspected COVID-19 infections with mild symptoms. Place the patient in a well-ventilated single room, that is with open windows and an open door. Limit the movement of the patient and minimize the shared space. Household members should stay in a different room, or if that is possible, maintain a distance of at least 1 meter from the ill person. For example, sleep in a separate bed. Limit the number of caregivers, good health, and has no underlying disease. So the person who is a caregiver must be in good health and should not have any underlying disease. Visitors should not be allowed. Perform hand hygiene after contact with the patients or their immediate environment, before and after preparing food, before eating, after using the toilet, and whenever your hands look dirty. To contain the respiratory secretions, provide medical masks to the patient. Now, home care for the patients with the suspected COVID-19 infections with mild symptoms. Individuals who cannot tolerate a medical mask should use rigorous respiratory hygiene. Caregivers should wear a tightly fitted medical mask that covers their mouth and nose when in the same room as that of the patient. Avoid direct contact with the body fluids. Use disposable gloves and a mask when providing oral or respiratory care, and when handling stool, urine, and other waste. Perform hand hygiene before and after removing gloves and masks. Use dedicated linen and eating utensils for the patients. These items should be cleaned with soap and water after use and may be reused instead of being discarded. Clean and disinfect daily surfaces that are frequently touched in the room where the patient is being cared for, that is household soap or detergent, should be used first for cleaning and then after rinsing. Regular household disinfectant, that is sodium hypochlorite 1%, can be used. Now, the patient's clothes, bed linen, bath, and hand towels, using regular laundry soap and water or machine wash at 60 to 90 degrees centigrade with common household detergent, and the clothes have got to be dried very, very thoroughly, preferably in open sun. Now, use of mask is there to limit the spread of certain respiratory diseases. Mask alone is insufficient to provide adequate level of protection, and other equally relevant measures should be adopted, that is hand hygiene. Wearing medical masks when not indicated may cause unnecessary cost, procurement burden, and also it creates a false sense of security that can lead to neglecting other essential measures such as hand hygiene practices. Using a mask incorrectly may also hamper its effectiveness to reduce the risk of transmission. In the community settings, the use of mask is for the individuals, you see, who are there. Individuals without respiratory symptoms should avoid closed, crowded spaces, maintain a distance of 1 meter, practice hand and respiratory hygiene, refrain from touching face, nose, or mouth. There is no need of mask. So remember that the individuals without respiratory symptoms, they don't need any mask. Now, individuals with the respiratory symptoms, they should wear a medical mask, they should seek medical care, and they should also learn mask management as described before. Then in the home care settings, the use of mask is the individuals with the suspected infections with mild respiratory symptoms, relatives of caregivers, along with hand hygiene, keeping a distance from the affected individual as much as possible, and always I'm emphasizing at least 1 meter. Improve airflow in the living space by opening the windows as much as possible, and mask management. Then use of mask in the healthcare settings. The individuals with respiratory symptoms should wear a medical mask while waiting in the triage or waiting areas or during transportation within the facility. Wear a medical mask when staying in the cohorting areas which are dedicated to suspected or confirmed cases. Do not wear a medical mask when isolated in single rooms, but cover mouth and nose when coughing or sneezing with disposable paper tissues. Healthcare workers should wear a medical mask while providing care to the patient. Use a particular respirator that is N95 NIOSH certified, or basically it can be of European standard or equivalent when performing a aerosol generating procedure, which can be either tracheal intubation, non-invasive ventilation, or tracheostomy. Now, one more important thing, Yusuf, from the public health perspective is that what is the rationale for data information for COVID preparedness and response? We need data. We need data from all over. We need data from the districts. We need data from the grassroots levels and all that. Now, why this data is important? Data is very important for tracking of the cases and contacts and to provide care and treatment. It is also very important for rapid detection of new cases where the SARS-CoV-2 is not circulating. From there also we need data to provide epidemiological information, to conduct risk assessments at all levels, and also to provide epidemiological information to guide preparedness and response measures at all levels. We do have the special surveillance information system created by Ministry of Health, and you can look at the URL, that is ncdc.nhp.gov.in, and login credentials will be shared separately. Now, application mainly it is built on two-level users. One is data entry and the dashboard at the state level, and all data entry officers will be provided with the credentials of the application for making entries, which is already happening, and dashboard for data viewing at both state and national level. Now, there are few key considerations which we must keep in mind for the surveillance. One is surveillance period is at least for 28 days. That is for 14 days of quarantine at the home or hospital or a designated facility, and next 14 days is for self-reporting. Now, testing all the high-risk contacts to be tracked, quarantined, and lab tested as per protocol. For low-risk contacts, lab test only when the patient under surveillance develops symptoms. Samples can be, as I already told you, which can be throat swab. No drug is required or vaccine is recommended in the present scenario. Now, as far as you know, we have got other considerations for surveillance. Indian nationals, irrespective of location of the healthcare facility where the suspect or confirmed case is admitted, it will be included in the line list of the state where the case resided during the last 14 days prior to or after the onset of symptoms. In case of any conflict, the state may discuss the matter amongst themselves and take a decision. Foreign nationals, as far as they are concerned, an individual or group of foreign nationals, if found positive and admitted in a designated healthcare facility in a particular state, that state should include the foreigners in the line list. So these are some of the resources which are given over here, and I'm thankful to the material which has been provided, by FICCI as well. And these are some of the resource materials which you can always refer to. Now, if there are any questions, we'll be happy to take the questions. Thank you so much. Keep safe, keep a distance, maintain your respiratory and cough etiquettes. So social distancing in today's life becomes very, very important. And it is that not only in terms of it's a word, it is you have to practice it. But if you have a symptom, please report to the healthcare facility as early as possible. Thank you very much.
So now we will take the questions.
Yeah.
If anyone has any questions, you can please ask your questions in the questions tab.
Slides are not changing. Please fix the slide issue. Last lines of the slide can't be seen. Good morning, ma'am. So that is there.
If anyone has any question regarding this, please type your question.
Have you put the
Ma'am, one question has been received from Ekta. How do we differentiate between flu and COVID infection?
That I already mentioned. We can go back to the slide. We can go back. There was a table where we mentioned that, when we look at there's a table which clearly shows between the differentiation between the COVID-19 and flu, where fever is very common in both COVID-19 and flu. Dry cough is common, but shortness of breath is not there in flu. Headaches are more common in flu, and aches and pains are common more in flu. So primarily it is basically, it mimics, flu-like. That is why these are known as flu-like illnesses also. But then we have to mainly focus on fever, shortness of breath, and dry cough, which is marker of COVID-19, or it is indicative of, and we have to look towards that direction of, then we take the history of the contact and their history of travel and all. Is it?
Next question is, are masks effective if we are going outside just to protect ourselves?
Yeah. See, if you are asymptomatic, basically, and you are staying alone, then masks have no role. But if you are going out in a crowded place, or you are going out in a setting which involves, collection of more people, then it is better to wear a mask to protect yourself. But if you are asymptomatic yourself and you are confined to yourself in your office, in your rooms and all that, then there is no need to wear a mask.
Next question is the fecal-oral transmission confirmed?
Yeah, fecal-oral transmission is confirmed. They say that virus remains in the stool for about 3 to 4 weeks. So till you see the stools are declared negative of virus, we should not be considering the patient to be free from infection.
Can MR vaccine protect from COVID-19?
Right now, we cannot say anything, because we are talking about the vaccines that, the routine vaccines have to be postponed for about 4 weeks also. So it is important to look at from that perspective. But there is no evidence that MR vaccine can protect from COVID-19.
Next question is, what is the size of the coronavirus in micrometer?
It's more than 5 microns.
How food is not transmitting this disease?
Because normally the food what we are using is basically, we are heating it, we are this, and it's only the fomites have got to play important role. And I showed you where the virus is going to survive, on the surfaces, on the handles and all that. I gave you a long list of, in the tabular form, that how the virus is surviving, for how long it is surviving. You can refer to the PowerPoint presentation. But food is not a vehicle of transmission of infection.
If the virus attaches to human body via ACE2 enzyme, so will using ACE2 inhibitors help?
No. This is a very, very important question which is being asked, particularly in context of hypertensives. So right now, whether we are talking of persons who are on ACE inhibitors, they should continue taking them, because we are not going to disrupt their regimens. So stopping of the ACE inhibitors is not going to help.
What is the period of communicability?
The period of communicability is, the person can be there in the incubation period, and also, basically till the person is declared as non-infective. So that is where we talked of two things. One is, we talked about the first part is we are talking about the quarantine, and the second part is we are talking about the confirmed part. So first 14 days is meant for the incubation period, then that means the person is able to transmit the disease. So that is, we need to look at from that perspective.
Has community transmission been confirmed in India?
No, there is no community transmission which has been confirmed in India.
Will the hot weather have any effect on the transmission of the virus?
The hot weather is controversial, because some of the other countries also have this, all the countries have virus which have got, basically hot weather as well. So right now we cannot predict that it is going to have any role, but we are not very much proactive in looking at hot weather at this condition.
What is the criteria for community transmission?
From
stage 3, when
it is going to affect actually to the masses, in the thing that will be stage 3. And that means, when we look from, it will not be coming in contact with the international travelers. It will not be, there is coming in contact with a person, who has already had a contact with a traveler, or so this is where we need to, the disease is going to transmit to the common individual. Like, let's say, we were worried about community transmission just, few days back, when there was, all the people started migrating back, migrants, they started going back to their native places and all that. So community transmission, basically, when we get the large number of cases from the community itself.
Next question is, ma'am, if we isolate the COVID patients in special wards in hospital, but we are asking the mild cases who are at home to keep the doors and windows open, won't this cause spread of virus in the society?
See, basically, we have to remember that we have to prioritize our resources. We have got 80% of the cases who have got mild infections. And this is like any of the illnesses, it's like influenza-like illness. And over a period of time, the response or the cure will depend upon also the immune mechanism of the individual. So if we start filling the patients with our hospitals with the patients with the mild illnesses, it is not going to help us. So it is always better to prioritize our resources, because ultimately the illness is going to be self-limiting. So we need to particularly keep the individuals in isolation who are suffering from mild illnesses. So, but we need to keep a watch on them, and we need to give them alternatives like exercise, yoga, meditation, good food and all that. But they have to isolate themselves from others, and the room has got to be well ventilated.
Chances of infection in a child below 5 years.
See, now, earlier it was not there. Now we are, getting the cases in children as well. So this is where Indian Academy of Pediatrics is coming out with the recommendations. So earlier the chances were not there.
How are we managing COVID patients in our LNJP hospital since there is no known treatment?
See, right now, not only in LNGP hospital, across the world, basically we are managing the patients empirically. And, if you will remember, the first few individuals who were there from Rajasthan, where we started giving them antiretroviral drugs, which were basically related to anti-HIV treatment. That means we tried oseltamivir and all that. These drugs, antiretrovirals, were tried on them.
Is there any role of blood sample in COVID-19 diagnosis?
No, blood sample plays a very, very important role in, when we are talking of pneumonia and all that, so that, because pneumonia is a common presentation of the severe illnesses also. So subsequently, right now, as we are talking of blood samples, particularly for blood cultures and all that in pneumonia cases.
The next question on community spread is already answered. What is the current strategy of our MAMC PSM department among this pandemic?
You see, community medicine departments have got a very, very important role to play. Number one is the job of awareness creation. Number two is we have got rural and urban centers where we can monitor influenza-like illnesses, and amongst them, the cases with the severe illnesses can be referred for further diagnosis and management. The third important part is we have got a very, very important role in surveillance. And as I told you, data is a very, very crucial thing. Our teams are also integrating with National Centers for Disease Control for strengthening of our IDSP, because surveillance is the crucial thing at this point. We need to know the trends of the disease. So this is so holistically we are looking at the capacity building, we are looking at monitoring of influenza-like illnesses, we are looking at IDSP program, and also you see in terms of training to an individual, to the community, to the frontline workers, that is also where MAMC PSM department is playing a very important role.
When do we say patient has recovered?
See, when the tests are negative, we say that. And another thing which I also told you, now we are looking at the stool samples also. When stool samples are also negative for the virus, then we say that the patient has recovered.
Why is it named COVID-19?
It is known as coronavirus infectious disease, discovered in 2019.
Are patients taking ACE inhibitors at a greater risk? Already answered. Animal to human transmission and vice versa?
animal to human transmission is there. Now we can't say about the vice versa part. That is.
Role of hydroxychloroquine in prophylaxis.
Role of hydroxychloroquine in prophylaxis of healthcare workers in between came, but we do have a, please go to the WHO website, read, this has got not a very, positive role. So it is, the healthy individuals must not take hydroxychloroquine just for the sake of taking. So I will not say right now hydroxychloroquine has got much role in prophylaxis, particularly in cases of healthy individuals.
Does virus show vertical transmission or transplacental transmission, as it has to be monitored in pregnancy?
See, occasional one case has been, reported from USA, but we cannot say definitely it was a transplacental this thing unless we have a big data to support this. But we definitely are very cautious about monitoring the pregnant mothers now. But since we are in a very early stage, so we cannot comment upon the vertical transmission of the disease.
GIT symptoms of COVID-19, is it true?
No.
What treatment is being given presently and what is its effectiveness?
As I told you, we are only doing hit and trial. We are doing the management of symptomatics. We are doing an anti-HIV treatment. We are trying. So basically, it has to be on the basis of presentation. We have to take the action accordingly. If there's pneumonia, pneumonia has got to be treated because it may be bacterial pneumonia as well. So comorbidities need to be treated. So we do not have a correct vaccine. We do not have a correct, we'll say that this is the drug which is there. So we do not have right now those conditions.
Are there any alternatives to masks? Not everyone was able to procure them and now they are not available anywhere.
As I told you in my, I think there were a lot of slides on masks which talked about extensively about the judicial use of masks. As I said that masks, they need to be used only in those settings which are potentially infective to the individuals. Particularly when you're working in the healthcare settings, you need to wear a mask. And also it depends on, like if it is a OPD setting of a rural health center, urban center, there is no need basically to wear a mask which is N95 mask. But then the second part is we need to look at also that if you are asymptomatic yourself and you are working in an environment which is known to you, there are not many people, you need not wear a mask. But if you are going in an overcrowded environment, you need to wear a mask to protect yourself because you do not know that another person may be symptomatic. But if you are symptomatic yourself, you must wear a mask. So please look at the mask slides also very, very carefully.
Transmission through food has already been discussed. Chemoprophylaxis has been discussed. Is transmission by air completely ruled out?
No. Because particularly when we are talking of aerosols and all that, that has not been ruled out.
Why is the number of cases in India so low even though we imposed a lockdown after most other countries?
See, one thing is it has got to do with so many things. One could be genetic makeup. Second is the immunological predisposition of the individual and all that. And you see, susceptibility of the host becomes very, very important. The genetic makeup of the individual becomes very important. So that is where we need to see, and on an individual, if we see that from the childhood also, our average Indian child has got 3 to 5 attacks of acute respiratory illnesses and all. Probably, I think the immune mechanism has also got a lot to do. But definitely, you see, I will not say that since we are talking of less number of cases because of lockdown and all that, the lockdown will definitely help us in preventing the spread of the infection, which is one of the most critical and crucial action so far being taken. Because when we will remain in self-isolation, when we will be distancing ourselves, when we will be greeting others only from far away distance, this is the way when we will not come in contact with the individual. And the maximum range of transmission of infection is only up to 2 meters because the droplets are very heavy and they settle down fast. So this is where we need to look at that. One of the important thing is that lockdown will play a very, very critical role, but we cannot say that Indians per se have got we have got in Indian context we have got less number of cases only because of the lockdown, it is because of other things as well. But lockdown has, or distancing has got a very, very important role. And also please remember that traditionally our welcoming style of namaste also is playing its dividends at this juncture.
For people living in poor conditions, like single room with more than 3 people in the same room without 24-hour water supply, what advice can be given to prevent the transmission among them?
See, we do have this as a common scenario in our urban slums, in rural areas also. We do have people who are staying in single room with more than 3 or more than 4 also. There is no 24 hours water supply also. So idea is basically that if there is somebody who is really suffering from severe infection, he needs to be isolated or he needs to go to the healthcare facility to consult. But primarily it is very important to maintain a social distance also. Number one, distance yourself, keep your faces towards the opposite side, not to share the same beds. It is very important to follow the routine etiquettes, that is preventive etiquettes at this point of time. And then hand hygiene again has got a very important role to play. Cover your while sneezing and all, we can say that you must sneeze in your elbow. So that is another important thing. So basic hygiene etiquettes have got to be taught to all.
Why are we not using the testing kits developed by the Pune lab, which can test only in rupees 12 per person?
See, right now we are going by ICMR guidelines and we are going by test kits which are having very high sensitivity. And these tests which are yesterday also, this was much there in the TV channels also. So we are using now MyLab kits also, which are also, doing real-time RT-PCR. So unless these tests are really done, we accept them by real-time testing, and we have to check the sensitivity specificity as well.
How much effective are antivirals in the current treatment?
See, till we give them these antiretrovirals to large number of clients, we will know their effectivity. But initially, the 2 patients who were there in Rajasthan, foreign nationals, they were treated with antiretroviral and they responded effectively. As of now, we have got no this thing, so we no specific antivirals which are there. So we are using antiretrovirals which were given for HIV treatment. I think we can just say that.
Okay, almost other questions are just a repeat of what have already been answered. How many confirmed cases are there in LNJP hospital? You can check the ministry website for that. It is a dynamic number. Are we getting attendance? Yes, you are getting attendance. We get the time when you log in and we get the time when you log out.
One thing which you must keep in mind is that the disease is amongst us. You need not go by numbers that today it may be, I'll say 130 patients, 140 patients. That does not make this thing. You have to accept the fact that COVID-19 is there in India and we need to follow at least social distancing, hand etiquettes. We need to report to the healthcare facility if we are symptomatic. So please follow these guidelines. So that is very important. And every time, from the health media, from the chief minister, from the prime minister, you are hearing these messages, and do follow those advices.
Do we need to show them the websites?
Yeah, we'll show you the websites as well.
So these are the different websites which you can see to check for any data. This is the WHO website. On the WHO website, there is a dashboard you can see here. I hope you are able to see the screen. So this is the dashboard. In the dashboard, when you click, this is the real-time data where you can see where all the cases are coming. You can see it country-wise. When you click on the country, you can see the country wise distribution also. If you
So this is a very, very important site and very authentic site. So you can click on that and you can look at the number of cases according to the country.
So this, if we click on India.
Yeah, so 1251 cases. So this is as per our WHO. This thing, as I told you, WHO is little, we are 5.5 hours behind, ahead of them. So it takes time for them to load that. So these are all the confirmed cases on the WHO website, and this is a dynamic website which should be referred to. The second, this thing is also we need to
then
look
you
at,
can also go to the Ministry of Health website,
which is a very busy website, and most, maximum number of people are accessing in lakhs and lakhs this website, but a very authentic website which talks about, COVID-19 India as on 31st March 2020, where it reported 1238, that is 1238 active cases, 123 discharged, 35 deaths, 1 migrated, and all that. But besides this, this also will show you the new advisories, new guidelines, and you must follow Ministry of Health and Family Welfare guidelines only in all the conditions. We cannot adopt them and make them modified according to our conditions. And you can see over here also what are the instructions given regarding travels, what are the restrictions on international passengers, then what are the visa restrictions, then also now we have got additional this thing on behavioral health. Now as the our epidemic is, our pandemic is advancing, we see more and more cases of mental illnesses and all. So it is important to take care of the behavioral or psychosocial part of it, and we have given a toll-free number also with regard to that, and IBHAS is our nodal center for that also. Then we can show them this. We also have got please have a look at this e-learning course for healthcare workers on COVID-19, and which is very, very comprehensive. This has been prepared along with the Indian Association of Preventive and Social Medicine, Department of Community Medicine, Maulana Azad Medical College, under the aegis of Niti Aayog in collaboration with FICCI. So this is a e-learning course for healthcare workers, which is there in 3 modules. Module 1 talks about COVID-19. Module 2 is again very exhaustive. It talks about infection prevention and control. And module 3 talks about clinical management of COVID-19.
You can also search for Mythbuster. There are various myths regarding to coronavirus. You can just search for Mythbusters. There is a WHO page and a National Health Portal page also. You can just click and you can check all the myths. Many people have asked many questions related to the myths. You can just check these myths and check the exact facts that are there related to that myth.
See, there is the last very interesting question is, when will we return to our normal lives? Normal lives is your perception, basically. I'll say that each one of you has to redefine for yourself what is the way of living, because over a period of time, somewhere, we forget about ourselves. We do not pay attention to our own health. Accordingly, our lifestyles are not regulated. So see that, basically we have to relook and redefine our own lifestyles along with your studies and all that. If you're a student and this question has come from a student, I can make out. So please see that, how we can follow the healthy lifestyles and how we can regulate our pattern of living.
Who do we call a super spreader?
The super spreader is a fast spreader virus. So this is where, so viruses are slow spreaders and super spreaders also. The virus which infects very fast, substantial number of individuals, they are known as super spreaders.
Many people have asked the role of antivirals in COVID treatment.
Yeah, that's what I said. Flavavir, remdesivir, and all that. You see, primarily, we cannot say with great authenticity that they are going to be helpful, but few of the antiretrovirals which have been tried and they are still being used, you see, on the patients, we are yet to see, that for sure these are the ones which are going to be effective. So we need to make the recommendations on the basis of, we are just trying them.
Why are we not doing adequate screening? Why is it only limited to the ones who are in direct contact?
I think it is better to rationalize your screening. We cannot, you see, how are you going to prioritize your resources? First, we have to look at the individuals whom we are suspecting that they are going to have the disease, like persons who have had a history of travel, or the persons who and they travel and they felt sick, then persons who came in contact with them, like yesterday we had also a cluster from Nizamuddin. So our priority resources will go to them and their contacts first. If we start testing anyone and everyone indiscriminately, I think that will not be appropriate use of resources.
Is super spreader a virus or the person? It is the person infected. So I think all the questions are answered, and any queries that you further have, you can just reply to the mail that you receive. So we will be closing this session now. Thank you for attending.